Hi, everybody. We're so glad that you could all make it with us today as we talk about how to defend inpatient authorization denials. Yay! Okay, our presenters today are going to be Reggie Wilson, I'm sorry, Reggie Allen, and Denise Wilson. And so we have a few housekeeping slides that we need to take care of here. So let's do that first. All right, as you can see here, you have a control panel and it shows you where you can join the audio. You can choose the telephone and dial in if you want to. It shows you where we have handouts that are all ready for you. You can just download them. And then we have a questions panel down toward the bottom. So you can submit any questions and comments. And if we have some time at the end, which we try to build in some time, we'll do our best to answer some questions. And in the next couple of weeks, we'll do our best to answer other questions that we didn't get to. As far as CEUs and contact hours, as you know, free CEUs are offered to AHDAM members only. To get the CEUs, you have to attend the live webinar for at least 15 minutes and complete the survey that will pop up automatically for you at the end of the webinar. So those two things, 90 minutes and 15 minutes, 15 minutes and the survey. We will email the CEU certificates to you. Unfortunately, they are not available just for watching the recording. You have to be here live and answer the survey. The disclosure is we don't have anybody in a position to control content for this activity that have any relevant financial relationships to declare. Now, whenever the survey pops up, you will be prompted to select the CEUs that you want. There are a variety of that you can choose from, and you can choose one or all. We do have another complimentary webinar coming up next month on August 23rd, and it will be a companion webinar to the one from today. It will be successfully defending outpatient authorization denials. And again, CEUs for AHDAM members only, and you can register at the homepage at www.ahdam.org, and we certainly hope you can join us for that one. Now, a little bit about AHDAM. AHDAM is the Association for Healthcare Denial and Appeal Management. It's the nation's only association dedicated to healthcare denial and appeal management. Our mission is to support and promote professionals working in the field of healthcare insurance denial and appeal management through education and collaboration. Our vision is to create an even playing field where patients and healthcare providers are successful in persuading medical insurers to make proper payment decisions. And there is our website address. And AHDAM is created through the generous support of PayerWatch. And just a little bit about PayerWatch. We have PayerWatch AppealMasters, where thousands have been trained in denial and appeal management, and we do strongly believe in taking your appeals all the way. And a clinical legal approach is also very beneficial. PayerWatch Veracity is software that has been developed. It is a leader in the industry, and we protect revenue in service to providers. Now, there is a disclaimer. I do need to read this. The Association for Healthcare Denial and Appeal Management publishes and distributes materials on its website that are created by our members or invited industry subject matter experts for the benefit of all AHDAM members. AHDAM does not certify the accuracy or authority of these materials. These materials are distributed and presented as research information to be used by AHDAM members in conjunction with other research deemed necessary in the exercise of AHDAM members' independent professional judgment. AHDAM claims no liability in relation to reliance on the content of these materials. The views expressed in the materials are the views of the materials' authors and do not necessarily represent the views of AHDAM. Any references are provided for informational purposes only and do not constitute endorsement of any sources. There are no conflicts of interest to declare for any individual in a position to control the content of this presentation. So a little bit about Denise. I think a lot of you know Denise. She's been doing this for a long time. She is the Senior Vice President of PayerWatch and AppealMasters and President of AHDAM. Denise has over 30 years of experience in healthcare, including clinical management, education, compliance, and appeal writing, and extensive experience as a medical appeals expert. She's a nationally known speaker and a dynamic educator in Medicare and commercial appeals processes, payer behavior, standards of care, and just anything and everything that you could think of appeal related. And we also have Reggie Allen with us. He is the Chief of Clinical and Business Operations at PayerWatch. And Reggie has more than 35 years of experience in a variety of healthcare positions, including staff nurse, nurse manager, chief nursing officer, chief operating officer, vice president of clinical business operations transformation. He's nationally recognized as an expert in care management and clinical operations. And he obtained his bachelor's from Vanderbilt, MBA from the University of Phoenix, a member of Case Management Association, and the American College of Healthcare Executives. And we are delighted to have Reggie join us today. Okay, so now we're going to get into the webinar itself. So Denise, I'll turn it over to you.
Sure. Thanks. Thank you, Carla. So I always like to start out our webinars with just a little bit of background and kind of information about what we're talking about today, just to make sure everybody's on the same page as people are joining and settling in, make sure we're all talking the same language. So pre-authorization, thought I would just start with what is the meaning and purpose of that. And basically pre-authorization is a utilization management tool that payers, insurance companies use to help manage what kind of services are being utilized by their beneficiaries. And utilization management is not a bad thing in theory and in concept, because it only makes sense that you purchase insurance. Insurance is going to cover things that are reasonable and necessary to maintain or improve your health, but it doesn't make sense for them to pay for things that are experimental, that cost hundreds of thousands of dollars if it's not appropriate to treat your particular condition. So that's really what it's all about. And so pre-authorization is a way for the health insurer to make a decision up front about the service, the treatment plan, the drugs, durable medical equipment, what's medically necessary for you. So sometimes it's called prior auth, prior approval, pre-certification, pre-authorization. Those terms are a lot of times used kind of interchangeably. Your health insurance or a health plan may require pre-authorization for a variety of services before you receive them, except in an emergency. So they cannot deny services that were required because you suffered a medical emergency. It's also not a promise, and we talk about this all the time, it's not a promise that your health insurance or plan will cover the cost. They're just saying at the time that you have requested a service to be covered by an insurance company, the information they have at that time, they may say, yes, we will cover it. But if something changes, something different happens, or with information was withheld, they can come back and say, we're not going to cover it because that was not the information they were provided at the time that they issued authorization. So no, it's not a promise that they're going to cover your costs. Okay, next slide.
Trying.
There you go. Oh, I see your pointer anyway. Your mouse.
Yeah. There we go.
She found the right key. All right, so I already talked about this a little bit. Are the services medically necessary? Meaning, are they evidence-based? Do we have studies that say this is appropriate for the services that you're being provided? Is it effective? is it safe? Obviously, they're not going to pay for care that they feel would not be safe for you. And then cost efficiency is a big part of it because we can't have health insurance if our health insurance plans don't stay in business. So yeah, they have to be cognizant of how much it's costing to provide that care, and especially if it's, like I said, if it's a very, very expensive treatment or drug or durable medical equipment, we want to make sure that the dollars that are in our healthcare system are there being used efficiently. So some of the negatives or the cons to having pre-authorization is that it can be very burdensome on providers because they're the ones who are trying to obtain that pre-auth for their patients. And then it can also cause a delay in services being provided for patients or non-coverage of services for patients. So those are some of the not so great parts of having to go through pre-authorization. Okay, I think the next slide is mine.
I don't know why it's lagging here. I'm so sorry.
That's okay. Usually if you just click your mouse on your screen, it will allow you then to pass to the next slide. There you go. The Affordable Care Act prohibits health plans from requiring prior auth for emergency services. So it doesn't matter whether you're in network or out of network for any particular payer. Your insurers cannot require prior auth if emergency services are occurring, and that includes some behavioral health services as well. Because remember, those can be emergency services as well. A patient comes into the ER, in a crisis. They can't require pre-auth before you begin care for that particular patient. So prior auth requirements for treatment of mental health and substance use disorders also cannot be more restrictive than prior auth requirements that the plan has for other medical services. So that's just something to keep in mind, tuck in the back of your brain there, because if you're, writing an appeal for something that has been denied for prior auth, just remember they can't be more restrictive if it's a mental health substance use disorder than they are when they're authorizing medical services. You did it, Carla. Good job. So, as we said, it's not a promise to pay. The managed Medicare, speaking about managed Medicare specifically, in the CFR stands for the Code of Federal Regulations. Okay, so the Code of Federal Regulations is the governing laws over Medicare and managed Medicare. When they say about prior authorization that if the MA organization approves the furnishing of a covered item or service through a prior auth or pre-service determination of coverage or payment, it may not deny coverage later on the basis of lack of medical necessity. Okay, so this is the newest language that just came out with the final rule on Medicare Advantage plans that came out. We did a webinar on it a couple of webinars ago, I think. The CMS 4201F final rule, where it's in the regulations now, but it technically doesn't really go into effect till January 2024. But gosh, we're close enough now, that I mean, it's worthwhile arguing it. People argue it in their appeals all the time. They may ignore it. MA plans may ignore it right now, but it doesn't hurt to start getting it in there. Get it in your template to start using it now. So this was a clarification from the final rule that came out. I've got the listing there, the URL there for where you can find this in the Code of Federal Regulations if you want to read it in context. What it did say in the Managed Care Manual, Chapter 4, or what it does say right now, because I don't think they've updated it yet when I was creating these slides. What it says now in the Medicare Managed Care Manual, Chapter 4, it says if the plan approved the furnishing of a service to an advanced determination of coverage, it may not deny coverage later on the basis of a lack of medical necessity. And so a lot of people have used that in their appeals. I hear that from the community all the time. We use it in our appeals at AppealMasters as well. But a lot of the MA plans have just been ignoring that and saying it's still authorization, is not a promise of payment. Well, Medicare has come back and firmed that up with the final rule, where now they're saying, as is quoted there at the top of this slide, if they approve the furnishing of the service through a prior authorization, they cannot deny it later based on the lack of medical necessity. So that's really, really important. And it's important to use that language back to Medicare, or to use it directly, or back to your Medicare Advantage plans. If you're seeing that happen, I would use that quote directly out of the CFR as part of your appeal process. Okay, so we're going to have Reggie Allen talk to us a bit about inpatient authorization and how to successfully defend against inpatient authorization denial.
Thank you, Denise, and I apologize to the group for not having my face here. I'm a little technically challenged, and I promise the next time. I'm assuming you saw my picture early. Some of you out there I know already know me, been around a long time, so the next time I'll get that fixed. I really want to talk about the process flow a little bit about inpatient authorizations. It really starts, as you can see, in number one, making sure that the service or procedure is actually really needed, that needs to happen. It's really a two-step process. Number one, we need to make sure that we verify insurance eligibility and authorization, that the patient indeed has insurance with that. That is just the first part. You typically will get an authorization number. However, we'll talk about that a little bit more and how that plays in. And then you then have to initiate the authorization based on the payer's protocols that they have set in place. They will give you an authorization number. That number is not good until the second step is completed, which is that you have to notify the payer utilization management with the clinical information. So the first part, all it does is an administrative authorization that indeed this is one of our clients, and here's your number. However, that number is not good until you do the UM piece. So if you start understanding how claims are adjudicated by payer, you'll start understanding that you may be calling. So example, with Humana, you may be talking to people in Lexington, where the corporate office is on the authorization piece, but the utilization piece may be done by a whole different entity, which is local, that you probably know those people that you're getting the auth from. So you'll validate the authorization number with them to make sure it's valid, that the one that they gave you. And then the seventh step of that is to follow up with the payer until the authorization is received. And that's important. I'll talk about that more. And then the last piece of this one, you need to make sure that you get the auth number in the system and on the claim. So 7 and 8 is really important. It goes back to what Denise talked about earlier. And that is, many of the payers are very reluctant they try to hold off before they give you an authorization number from the UM standpoint, because what they're trying to wait and see is if they can avoid paying you because the patient had a short length of stay. We'll talk about that more. When the claim is received in a claim shop, if there's no authorization number on that claim will be denied. So once the authorization number is obtained from the payer, we need to make sure that it's slotted on the claim, because that will be the first thing that the system will look for when it adjudicates it, to see if there is indeed an authorization number. And if it's not there, then the claim itself would kick out. I would tell you some of the things that you need to be aware of is the time frame for insurance notification of services. Some of them it's 24 hours. Some of them may be 24 hours by 10 a.m. the next day. Some of the insurance companies that we're now seeing have weekend staff. So I would say that your UM people may want to see if you need 24-hour utilization management services. That would be important. And you'll hear a lot more about the issue with verbal authorizations. So if you're still at a point where you're taking verbal authorizations, and when I say verbal, I am talking about denials and approvals of care. If you're still doing that by telephone and voicemail, yet I would really if I was you, look at your processes again, because, and usually most of the manuals, they're supposed to put something in writing for you when they when they're denying services. So this becomes a problem sometimes when we go to appeal these claims, and we'll talk a little bit more about that with the denial letters. But I would say be very, very careful if you still have those processes where they can call you on the phone and just deny a case or leave you a voicemail. It may leave you in a precarious situation when time comes to go to appeal the claim. Next slide. I would say the challenges, and Denise talked about those, are the inconsistent and ever-changing payer rules that we see. Even though it may be Humana and they have various entities or Blue Cross or whatever, there are restrictions with payer different from plan to plan. So all of these payers have multiple plans, and you kind of need to know what those rules are with those plans. The other issue that we see that's a strategy, that the challenges, I'm sorry, is getting the revenue cycle to link with the clinical team. We see where the administrative piece is done for the fact that the patient do the authorization, but then you later find out that the clinical piece was not done. And so now you're getting into medical necessity denials because we haven't figured out a way. And some of our clients have figured out a way that what they do on the insurance side gets moved over to the clinical side so that they know that they need to call in the clinicals for these patients. And then one of the other issues that we see that are challenges is when we're not using portals for insurance authorization. We have noticed the statistics say about 12% of the denials that we receive in overall are related to authorization. So in those cases, a lot of the stuff can be avoided through having some sort of automation that will go to verify if the patients have insurance or not, and if so, what plan are they actually on. Next slide. The strategies that I think that's more important that we have to do in order to really work very closely with getting authorization right is we need to make sure that we have a current master list of all of the procedures that require authorization, including the Medicare inpatient only list, because as Denise and them did on a previous presentation, shared with you that all the Medicare Advantages plans in the future are going to have to honor the Medicare inpatient only list. So you need that so that you're not, we still see places where inpatient procedures are done on an outpatient basis, which is not good. You need to make sure that you keep track of the clinical policy and guidelines changes of the payer, because you can have a procedure that today may not require prior authorization, but today it does. So we see that when we look for trends and patterns. Usually a lot of it is cardiac stuff, devices, things, high dollar items that may not have been subjected to pre-authorization before, but now that they are. We need to make sure that we're doing and training those people that are doing pre-authorization, both on the revenue cycle side and the clinical side, that there's education with them to know that both pieces are needed to manage authorizations. And this team should also review all the authorization denials and adjust processes accordingly. And my last location, we had meetings every Tuesday. We looked at every one of the denials we had received from the previous week. We identified what the root cause was, and we also put in what the action would be to make sure that that issue did not occur again. So I would challenge that if you are seeing authorization denials, that both teams, both the clinical team and the revenue cycle team that does the authorizations, come together and take a look at those. One of the other things that I think is very important for inpatient is to make sure that we have a great relationship with the payer contacts so we can speed up authorization decisions. Depending on how large your facility is or your team is, one of the things that you may want to consider that we did, and that was to make sure that the staff performed utilization management by payer. So that helped us know who, for example, Humana was assigned to our facility. It made it very quick and easy to speed up looking up authorizations to be able to get that done. You need to also make sure that you document all the communication that you have with the payer in your system. So this becomes very critical because today a lot of the authorizations are done at the time of service. And so those letters are setting in with the team, usually somewhere, and we need those denial letters to make their way wherever PFS is storing their information, so that when we are appealing a claim, we have access to what that denial notification was. So the integration of these two things is very, very critical. And so as we're trying to fight these things, many times the only thing that we have is some code that came back on the EOB, which may not be sufficient enough to tell us exactly why this denial occurred from the very beginning. The next slide. Again, I'm going to tell you we need to really understand and pay close attention to what the turnaround times are for rendering the decision on the request. Now, this is, and then we already talked about that being avoiding verbal approvals or denials. Get them to put in writing, just like they expect you to put in writing when you have to appeal when these cases on the back end. The other critical piece of this, and it will go back to Denise's slide when she was providing you with information about the federal code, is that we need to stay in contact with these payers every 24 hours until we get a decision. I see too many cases where we are trying to do an appeal on, and when we look at the notes, the note just continues to say that a decision was pending. Many of these payers have a policy that they should provide you with a decision within 24 hours. That's important because some of the appeals that we've done on authorization, we've been able to tell the payer, you should pay this claim because you did not make a decision within the 24-hour time frame. What they're trying to wait to see in many of these cases is if they can get away with, say, the patient has a short stay, and then they say, oh, this patient should have been in observation. No, they know that if they render a decision, they can't come back later and deny it. So we need to hold them to the fire and get a decision about them and provide them with any documentation that they need so a decision can be made while the patient is there. I would challenge everybody to continue to track and train their authorization denials. I'll show you a little bit more about that shortly. And we appeal all authorization denials based on the patient's clinical condition. You'll be surprised. I would say that I looked at our data. We have about a 96% overturn rate on authorizations because we approach it from the medical necessity and the condition of the patient. One of the other things that we don't do that I think would also be very helpful, if you understood that peers do not want family members to be upset with them because that affects their quality scores. So to do that, there are times that we really probably, especially when we're trying to get patients authorized for procedures or whatever, that we should engage the family. And the family can be very instrumental with having conversations with the payer. You'll be surprised how many times the payer will change their mind when the family or the patient is calling saying, I paid my premiums and you're denying my care. And then lastly, we've already talked about embracing electronic authorizations and payment boards. Next slide, please. I think Denise, is this you're going to do this one? I think you talked about this, about timeframes. There are no joint timeframes required for response. So we need to go to the payer contracts. Many of them have them in there, I promise you, that says that they will give you a decision within 24 hours. We need to hold them to that. And I think that Denise has already talked about the emergency coverage and what the maintenance and post-stabilization that they really should provide us a decision on those cases. Next slide, please. One of the things that we try to do, and I left for you, we're actually working to even to change all of ours, but really having a very detailed description and definition as you are actually looking at authorization denial. So you can do some trending to see if you're really having errors that are there. Looking to see where you might need to have referral for services. That will be, we'll talk about that I think next month when we talk about outpatient cases that we have. It's kind of nice to know if the error is from the payer or if the error is from actually from us, because there are things that we're not doing. So I think that would be very important. If you are not tracking and trending your authorizations, it will be an eye-opener for you of what may be the cause and what you might be putting in place. You may find, like we found in one of our locations, that we really needed staff on the weekend to actually make sure that we were notifying the payer and getting authorizations during that time frame. Most of these payers now have staff, staff on the weekend. So that may be something that you may want to consider. I also would ask you to make sure that you look at and be aware of a lot of the retro authorization denials, which usually occur when the patients don't pay their premiums, and we have to go back and write a medical necessity for them, but then allowed to go back and get authorization. So don't lose sight of those where you have patients that need to get their premiums paid or Medicaid pending or whatever. You'll have to go back and do retro authorizations on there. So somehow you need to have a tickler system to keep up with those so that you make sure that you get your money. Next slide.
So yeah,
yes.
So Reggie and I have been talking about this quite a bit recently about these root causes for denials when it comes to inpatient authorization. And as he said, it can be a payer problem, it can be a provider problem, it can be a patient problem. So I think it's important to kind of, make sure that you have your root causes separated them out in that way, because then you can easily grab what are the payer problems, and you can work through your joint operating committee or other means to try to clean up those problems that you're having with the payer. And then what are your provider problems? Do you know what problems you need to work on? The patient problems are a little harder to solve, I think, but make sure as you're creating your root cause denial list that you have them identified by, is it a provider problem, payer problem, or patient problem?
Good point, Denise. And that's kind of what we've done to kind of, as we work on our appeals, we're trying to identify so that we can help our clients understand where their issue may be. Next slide. I want to talk about appealing authorizations. I think it's important that you be knowledgeable of the payer screening criteria, but I want to remind everybody that it's just what it is. It's screening criteria. And so it doesn't always take into, the fact that many of these patients have multiple conditions. When I have been writing the appeals for authorization, I tend to see people use MCG criteria, for example, and they say this patient doesn't meet the criteria for, let's say, pneumonia. Okay, so they'll quote that, and they'll quote for me exactly what those elements of what they say that constitutes pneumonia. What they don't do when they use MCG criteria is they don't add the other piece that MCG has, which is what they call multiple condition guidelines. So MCG recognizes that a patient, yes, primary may be pneumonia, but with that pneumonia, they also may have COPD or diabetes, and you have to add those other multiple conditions to it. So when we're writing our appeals, we're looking at the whole entire patient and not just one. Very few Medicare patients have one diagnosis. So all that needs to be taken in consideration when you are appealing authorization denials. Then we need to understand some of them. Most of them in their manuals also talk about extenuating circumstances by the payer for failure to get authorization. So you have to tell why you didn't get authorization at the time that the patient was admitted to the hospital. I've left a few of them here that I think could be very helpful. We tend to obviously try to look. I see many of the cases where patients, let's say, came in, was extremely ill, was intubated. As in EMTALA law, as you well know, we do not treat a patient based on the type of insurance that they have. So, I can, after I write my medical necessity denial, I can go in and say, yes, this patient, not only this medical condition, but the patient was received, the patient was obtunded, the patient was in respiratory distress, blah, 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 blah. And then try to identify the extenuating circumstances that may be cause the failure to get authorization. However, at the end of the day, many of the patients, as we see Medicare, even though they may belong to a Medicare Advantage plan, still have their red, white, and blue card. And so it's not uncommon for them to present to that. And the payers also know that I'm really not responsible for them not having access or having the correct card. That's really on the provider, or on the payer to educate their members about keeping their insurance cards with them. But we really try to find a reason of why the patient we did not get authorization at the time. And I will tell you, when I'm reviewing many of the charts, usually I can see things like patients that they were self-pay, they had dementia, they were unresponsive, we added on procedures or whatever. We'll talk about it in the outpatient, but those are many of the reasons why we may not here. Several of them are extenuating. So make sure you always identify what those extenuating circumstances are. And my next slide, and then we'll let Denise go into some of the case studies. Make sure when you craft your medical necessity appeal letter, you always, for authorization, you always try to come from a medical necessity that this patient was sick and what that illness was for the patient. And you need to paint the picture of the emergency nature of this patient, or why this patient needed to be admitted to the hospital. Then what so the request is really based on the patient's clinical state. We always state the extenuating circumstances. So on the slide before, we try to identify what may have been the reason why we didn't get authorization. And then it's always good to quote that good faith clause that your patient was da-da-da-da, and we provide them with the highest level of care while considering what their condition was, blah, 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 blah. And then we always thank them, the peer, for their reconsideration of looking at this case and overturning it. And like I say, most of the time you'll find in authorization cases, the patient should have been there. There are always usually some extenuating circumstances of why we didn't know that the patient had insurance or whatever. And I will tell you, about 96% of these cases pretty much always get overturned once you address it in terms of the medical necessity need of the patient. Over to you, Denise, now for your authorizations, your case studies.
Case study. Thank you, Reggie. So we did put one case study in here. I know you all always enjoy seeing case studies and ask for case studies whenever possible. So this was one that was overturned. Authorization was not requested by the provider. So in the appeal, our appeal writer actually wrote it in a series of numbered statements. You could obviously write it as a narrative, but they just explain why the authorization was not requested. why the hospital did not request authorization. So there were extenuating circumstances that existed that prevented the hospital from requesting authorization from WellCare in a timely manner. So first of all, the patient didn't have an insurance card with him when he was sent to the emergency department from his cardiologist's office. Probably his cardiologist probably stuck in his pocket, right? So they give it back to the patient. No, I'm just kidding. He was sent to the emergency department from a cardiologist's office, didn't have his insurance card with him. Hospital staff went into the portal, found an insurance card for him from United Healthcare. But the expiration date on the United Healthcare card was 12/31/9999. And so they contacted United Healthcare, and UHC said, here's an authorization number. Then it wasn't until August 10th, so this was March 3rd to March 5th when the patient was in the hospital. It wasn't until August 10th that the hospital staff realized the patient was not covered under UHC. They determined the patient was covered under WellCare. So on the 12th, they contacted WellCare. They talked to Mary, so they wrote that in the appeal letter. I think that's fine if you want to note date, time, who you talked to. And she said she was unable to process a retro authorization, which was what Reggie was talking about, retro authorization over the phone. So this is, going back and asking for authorization after care has taken place, and you are trying to determine authorization from the correct payer. So she said, I can't give it to you over the phone, but she did request that the inpatient authorization form for admission be faxed to them. And when the hospital faxed that form to WellCare then subsequently denied retro authorization for untimely notification. Let's go on to the next slide. I thought this was the one that was overturned. Sorry. Go back to the previous slide there, Carla. I think I may have written that wrong. They approved retro authorization of the care, because this was one that did get overturned. So, okay, back to the next slide. So as Reggie said, make sure you include your medical necessity argument in your appeal. And so this was the argument that was in this particular appeal. 78-year-old gentleman who presented to his cardiologist's office on lightheadedness and dizziness with chest pressure. He had new onset of AFib with rapid ventricular response. He was sent to the hospital from the cardiologist's office. When he was at the hospital, metoprolol was started for rhythm control, but that resulted in bradycardia, so they started him on amiodarone instead. Then he underwent a successful radiofrequency ablation. And then number 3 here was just a snippet right out of the chart itself, the patient's chart itself. This is what the physician had documented in his note after the radiofrequency ablation. And I thought this was a really good note from the physician supporting, why the patient needed to be an inpatient in the hospital. Now, whether he just wrote this off the top of his head or whether this is, a statement that they've got in their electronic medical record that they just pulled in. Either way, it's a good support for why the patient needed to stay in the hospital. So they talk about the procedural complexity, the transeptal puncture, extensive ablation lesion set. That makes the patient at risk for peri-procedural complications such as cardiac tamponade, bleeding, hematoma, thromboembolic phenomena. The patient will therefore be admitted on an inpatient basis for heparin infusion and close monitoring. So that's really good support. Even though it's based primarily on risk, and we know payers a lot of times don't want to pay for inpatient admission based only on risk, it's still a valid argument, and it's still, in my mind, in my opinion, one of the arguments that we use to support the admission. Okay, next page. Or next slide. So some ideas on appealing when criteria not met. So Reggie was talking about that, how payers have criteria that they use to determine whether the patient should be admitted or not as an inpatient, MCG being one of them. Interqual is used a lot as well. So here's my thoughts on how do you appeal in these situations where you've asked for authorization, they've come back and said, no, we're not going to authorize admission because the criteria was not met. So one way you can argue it is if the criteria was met, but they applied it, the payer applied it incorrectly. Or there's an alternate criteria that was met because the patient had multiple conditions that they were being admitted for. If you know that you have a payer and you have experience with that payer, that you know if you go back to them and say, okay, they didn't meet for CHF, but they met for pneumonia, and that payer says, okay, we'll accept that, then argue that, make that your argument, and it's a quick, easy, that's your easy button. That's a quick, easy overturn. So that's fine if that's working for you. The other way you can appeal is arguing that these criteria are merely objective tools to help guide physicians in decision making. They don't always take into account specific comorbid conditions, and they weren't designed to replace a physician's professional training and expertise. So that's always a good argument to have as well. You can have that templated out, that language, 3 or 4 sentences that you could very easily either have it in your appeal letter template or have it available to plug in there whenever you're arguing these. And then the third one is that the care provided represented the standard of care in the medical community. So that's always part of your appeal. Even if when you're appealing for medical necessity of the inpatient admission, you should always have an argument that that is the standard of care. The way the patient was treated is the standard of care in the medical community, whether you're arguing for or against criteria or not. I would still include that. Okay, next slide.
Excuse me just a second. There's some sort of pounding in the background. Is there anybody who is not muted that should be? Paper shuffling. If anybody that is not muted, please mute. Thank you. Okay, here's the next slide, Denise.
Thank you. Okay, so some takeaways from today's presentation. Pre-authorization, as we said, it's not a promise that your health insurance or plan will cover the cost. There's still a process that we need to go through with our payers, and there's good reasons behind that. The Affordable Care Act does prohibit plans from requiring prior auth, or if it's emergency services, doesn't matter if they're in or out of network. And don't forget that includes behavioral health emergency services as well. As Reggie said, know your payer's turnaround times for rendering a decision on a request. So, hold their feet to the fire and make sure they are giving you decisions on your request, and try to avoid verbal approvals or denials as much as possible. And then very important to track and trend authorization denial causes, because that's going to help you understand how you can help prevent ongoing authorization denials that have occurred because of breaks in your processes at your facility. That's the one that you're going to have the most control over. It also gives you information to go back to your payers and have those discussions. So I was just reading right this morning before this webinar that the OIG just issued a report 2 days ago about managed Medicaid and an audit that they did, and how many prior authorizations, not just for inpatient admission, the prior authorizations were being denied, and it was 1 out of 8 cases, which the OIG thought was particularly high. And so they recommended that Medicare have a little bit more oversight into what's going on with managed Medicaid. So we'll see what happens from that. Okay, next slide. Some resources and references for you.
Okay, we do have some questions, and hopefully Denise and Reggie can answer some of these. Here's one from Linda. Late notification denials when the patient does not have insurance info at the time of admission. We argue the hospital was not at fault, but we're not successful. Any ideas?
So my first question is, are you writing, is she writing a medical necessity denial? Some people have generic stuff where they just try to, just state the facts, but we come from a clinical standpoint. So we go back, start our letters talking about medically why this patient needed to be admitted. Then we, did discuss that the patient did not present insurance information at the time. Of course, we have to follow EMTALA because the patient was sick. So we saw that the patient needed to be treated, and then obviously we go back to our good faith statement. So I guess what I would say my recommendation is to make sure that when you're writing from a clinical standpoint of clinically why this patient needs to be admitted to the hospital.
Okay, thank you, Reggie. Cindy asked, what about emergency services and stabilization that is extended and we don't have insurance info, the patient is intubated and has altered mental status?
A good case, and this is extenuating circumstances, and we do very well with those. I mean, I just did one not too long ago. The patient, even a patient that showed up at one hospital, was had a stroke. The patient required intubation, was life flighted to another hospital. The hospital that they was life flighted with, they're in the same system. They denied that case, but I was able to get overturned by pointing out the fact that this patient was critically ill. And again, we in good faith took care of your client who was critically ill, as you can see above, blah, blah, blah. I laid the whole case out from start to finish when the patient got there, and we got an overturn. So I think back again, we need to make sure that we try to do authorizations, and some people just try to go back and get an authorization number with just extenuating circumstances. I would go back and appeal to the clinical side of the patient, and then I would come back to the extenuating circumstances.
Thanks, Reggie. Okay, here's another one. I think it might be at least partially answered, but I'm going to read it anyway. This is from Jenna. How would this apply to third-party auditors who come back post-claim and deny inpatient level of care, stating care could have been provided as observation?
Audit's a little bit different. Okay, most of the time the auditors are really, it's very rare that I see them now talking about medical necessity. More, I see them talking more about clinical validation and coding issues. I would first have a mechanism in place where you can make sure that you don't already have approval from this claim. Because if this claim has already been approved and you have that in writing from the payer, they should not be going back. We've had those too, and we've sent those back and said this claim was approved by the payer, and sometimes we've appealed it already from a medical necessity standpoint. I've already appealed it from a medical necessity standpoint. It's called double jeopardy. You can't come back and do that. So I would check to see if we have documentation, even where the claim may have been appealed before and it was overturned, and now they're trying to, auditors, remember, they're only looking at the way they make their money is very, very different. It's a whole nother section we have to talk about with audits. But audits are basically done for overpayments usually, not necessarily for medical necessity. And that's a whole different conversation. If that person want to email me or reach out to me separate from them, I'll be glad to talk to them about the audit.
Yeah, I think what Reggie said, I think is true, that auditors are third-party auditors. They're working with the payer, and I don't know that they always have their systems in place where they should be omitting cases that were approved at the time of approved, paid, denied, appealed, overturned. So it could be a problem of, not having good communication back and forth between the database from the payer and what the auditor is working off of. But I also go back to, if you're contracted with the payer, see what it says in your contract as well, or what their policies say about, about auditing activities, and just make sure that they're playing on the up and up as well, because that's really a whole part, of appeal management, denial appeal management, that a lot of us on these webinars are clinicians, and we're always thinking from the clinical side, but there's that whole legal, regulatory, contracting piece to business piece too, that we have to consider, that we're holding them accountable, the payers accountable, for acting in good faith, the way that they're holding us accountable for acting in good faith.
Let me add one other comment to Denise's that I was just thinking about. This is another prime example of how we get in trouble with verbal authorizations. And we have all these telephone lines that these people call and just leave a message on. So you don't have a paper trail for that. And when auditors come after that, we are able to go back for those our clients that actually run paper trails. We've encouraged them, get out of the, they want your appeals and stuff to be in writing. You should want their decisions in writing. So the issue that keeps coming up from this is that we take a lot of stuff off, which we should just shut all these verbal lines down, tell these guys, go back to the contract. I mean, we would like to have our stuff in writing. So that's very lazy of them to deny and then put it on a telephone message, but expect you to put in writing when you're trying to appeal. So I would, again, go back, look at your practices. If you have no documentation, it's very, very difficult when we're working with our clients many times. When I said, where's the document? Do you have any documentation about this? Oh, well, no, they left a message on our telephone line. Okay, does anybody have the message? I mean, I can't find the messages because we allow a lot of this activity to go on. But good question. That was a great question.
Yeah, it was. Okay, here's one from Mary. Any suggestions on how to insist on getting denial or approval decision issued prior to patient discharge?
Contract. When I was in the field, Humana said that they would render a decision in 24 hours. I met with in our provider meetings. They told us that they will render a decision in 24 hours. And if I didn't get one, I used that in my appeal arguments. It was still pending when the patient left. And again, that's a strategy to see if we don't have to pay for an inpatient stay. We can wait to the end and deny you on observation. I told you what was going on with the patient at the very beginning, what was going on. It's not, I always remind the team, you can't be a Monday morning quarterback after a Sunday game. You have to be in the game when the game is being played. So we need to hold them to being in the game on Sunday when the game is played, and I need a decision. And don't leave those open. I just think you have to push it with them to get an answer.
Okay, thank you. Okay, here's one from Shannon. This is kind of a complicated one. Can you speak to the UHC's short stay billing validation? And Denise, I think this is what you just wrote an article about. Okay, they will authorize a one-day inpatient stay for a Medicare patient, then deny payment later, citing SSBV, which ignores the auth in Medicare regs and also states it is not a medical necessity review.
Yeah, so this is something that just popped up, at least for me, just popped up in the last several weeks. And I did write an article for the association on it. It's in our newsletter. So if you're a member, you can go in and read that. And there's also, if you're a member of the RAC relief, there's a lot of discussion on that as well. And also on Ernie De Los Santos, Finally Friday, we talked about it as well. So it was a pretty hot topic over the last 2 or 3 weeks where payers are coming, certain payers are coming back and saying they're reviewing short stays, inpatient versus outpatient observation, and they're calling them billing audits or billing validation or claim disputes. Because if they don't call it medical necessity, then that's a couple of things that happen for Medicare Advantage. If it's not a medical necessity denial, it's not open to you appealing it on behalf of the patient. And it also circumvents that new statement that I just read out of the final rule that says if it was authorized at the beginning, you cannot come back and deny it for medical necessity. So if you got authorization for the inpatient admission, you can't come back and deny it for medical necessity. So the payers, this is just kind of crazy to me. The payers are coming back and saying this isn't medical necessity. This is a billing dispute. You billed inpatient and you should have billed outpatient. So that's to me, that's just ridiculous. It's just nonsense. If you're seeing that and you need some tips on how to defend those types of denials, you can contact me at denise@AHDAM.org, and I'll be happy to give you some insight into that.
Okay, thank you, Denise, and thank you, Reggie. And I think we've run over just a bit here, 3:01, but we thank you all for your attendance and for your questions, lots of good questions, and we'll do our best to get to the rest of the questions within the next couple weeks. So, all right, hope you'll have a good rest of your day, and we'll see you next time. Bye now.
Bye-bye.